Hello, good morning and welcome to our online class on Basic Nursing 2. Last week we looked at feeding of patients and specifically we considered feeding a patient orally. This week I would like us to look at NG tube feeding. The NG tube stands for nasogastric tube, and like the name implies, it is a thin flexible tube that is inserted into the stomach through the patient's nose and esophagus. We use the NG tube to feed if we have a patient who is not fully conscious. So giving food to such a patient through the mouth is likely to result in something we call aspiration, where the food particles, rather than going into the stomach, passes through the airway, and that is a very bad experience. It can result in complications such as aspiration pneumonia. So whenever we have a patient who is not fully conscious and is likely to aspirate when food is given through the mouth, we resort to the nasogastric tube feeding. Nasogastric tube feeding may also be used for people who have had extensive trauma or injury to their oral cavity, as in the case of those involved in road traffic accidents. So with this category of patients, they are unable to feed through the mouth, and because of that, there is the need for us to pass a nasogastric tube and give the food through that. Nasogastric tube feeding may also be used for people with people in certain critical condition. If the condition of the patient is so critical, as in the case of those with severe burns, or let me say those with certain metabolic disorders, there is a need for us to give liquid food and through the nasogastric tube. So I know we have more, but basically these are the main indications or circumstances under which you would be giving or feeding a patient using the nasogastric tube. To do this, we need certain equipment and supplies. First, we will need a drip. Do not be confused by the word drip. It is simply a bead, what mostly we use to place on the chest of children before feeding them. So we need something to drip the patient so that in the course of giving the food, we will not have food dropping on the patient's burdens or clothing. That is why we need a drip. We need about a 20 to 50 cc syringe, or basically let's say we need a large bore syringe, a syringe that will be able to generate enough pressure for the food to flow. Then we need a pH indicator. We use the pH indicator to confirm the placement of the tube in the stomach. It is possible that you insert the nasogastric tube and instead of going to the stomach, it passes through the airways. So before we commence the feeding procedure, it is very important for us to confirm so as to be sure that the tube is still within the stomach, but not that of the respiratory passages. So because of that, we need a pH indicator to determine that, and mostly we use the blue litmus paper. Then we need items for mouthwash. Remember when we were looking at when we were treating basic nursing 1, we said the category of patients likely to suffer from a neglected mouth was those undergoing tube feeding. So yes, because we are always giving the food through the tube, we should not neglect the patient's mouth. So it's always advisable that if you have an unconscious patient or a patient in a very critical condition, whenever you feed the patient, it's important to also wash the mouth of the patient. And even patients who are fully conscious, but by virtue of the fact that they may be having some issues with their oral cavity that they must be fed through the NG tube, it is still important to give mouthwash, allowing the patient to rinse the mouth before commencement of the feeding would stimulate the peristaltic processes, that is, process the movement of the gut to allow for easy passage of the food. Then you would need the food that you are going to give, and of course it should be in a liquid form. This can take the form of light soup, diluted porridge, even some medications. Okay. As part of our procedure steps, the first and most important step is for you to explain what you are coming to do to the understanding of your patient. This is something that is not usual. It is not the usual way of taking food. So the patient may, for those that are conscious, even those that are unconscious, their relatives may become apprehensive because they would not understand why food would have to be given through the nose. So it's very important for you the nurse to explain to the understanding of the patient the nature of the procedure you are coming to perform, why you are going to do it, and then ways by which they can assist you to undertake this procedure. So yes, this is very important and must always be borne in mind when feeding a patient using the nasogastric tube. You have to provide privacy. This may appear very distressing to other patients observing. Besides, the one who is being fed will not feel comfortable. Like I told you, this is not a usual way of feeding. So when you are to perform nasogastric tube feeding, if it is in the general ward, it is recommended or advised that you screen the patient. But if it is in a private ward, you may just close nearby doors and windows so that passers-by will not be able to see whatever is happening to the patient. Okay, having done this, you would wash your hands and then assemble the needed requirements. And we already mentioned them. We said you need the food, you need a large bore syringe, you need a pH indicator, you have to drape the patient and add something for the patient, or mouthwash basically. So you assemble these items and send them to the patient's bedside and place it at a place that you can easily reach. The fact that I'm saying on the patient's locker or bedside table doesn't mean that they are the only items or the only places you can place the food. However, do not place the food on the patient's bed. Okay. Then you make the patient comfortable in a suitable position. With regards to the position, provided the condition of the patient would permit, it is advisable to put the patient in a sitting up position. With this position, gravity alongside the peristalsis will help in the movement or the flow of the feed down. But if the condition of the patient will not permit, any other suitable position may be explored to perform this procedure. Then you place the cape across the patient's chest. Remember, I said we should send a drape. This can take so many names. Others will say drape. It can be pronounced as cape, beep, or whatever you know it to be. But just remember to send something to place it across the patient's chest. And like I explained, it helps to prevent soiling the patient's dressings and beddings with the food that you are going to give. Then, prior to feeding the patient, it's important for us to aspirate the gastric content. What this means is that we use the syringe, the 20 to 50 ml syringe we sent. We use the syringe, place it on the opening of the NG tube, and withdraw some of the feed from the patient's stomach. Apart from just confirming the correct placement of the tube before commencing the feeding, aspirating also helps us to determine whether there was malabsorption with previous feedings. So it is possible that you gave food to the patient and that food has not been utilized and is still remaining adamant within the patient's stomach. So aspirating would let us also know that yes, absorption has taken place, or the food that was earlier on given is still inside, and for that matter, there may be the need for us to delay or withhold the feeding. So we aspirate purposely to confirm correct placement and then also to determine whether there was malabsorption. So when we aspirate the gastric content, we dip the blue litmus paper inside it. If it is within the stomach, remember the stomach is acidic, and from our basic integrated science we learned from the secondary schools, if you put a blue litmus paper in an acidic medium, the color of the paper is going to change to red. So when you aspirate and you place the litmus paper inside the stomach and you realize that the color of the paper has changed to red, it confirms correct placement of the tube within the stomach. Let me also add this. In the practical setting or in the world, you may be seeing people using other ways to confirm placement of the tube. But I must advise that the gold standard or the best way you can determine whether the tube is in the stomach is through imaging studies, where you would use either scans or x-rays to determine the correct placement of the tube. Another, or in the absence of the imaging, the most recommended method is for us to use the litmus paper. However, by virtue of the setting we find ourselves, excuse me to say, it's almost impossible to confirm using the imaging studies because the facilities are not there. That is why we mostly rely on the testing with the litmus paper. But in the wards, where even the litmus paper is a problem to come by, you may see people using things like putting a cup of or a bowl of water and dipping the end of the NG tube inside that bowl, such that when you see bubbling of water or when you see bubbling when the tube is inserted into the water, then it is suggestive that the tube is not in the gastrointestinal tract, but it is rather in the respiratory tract. Others will take let's say 5 to 10 ml of air or water. Then as they are flashing it through the tube, they are listening to the patient's chest with a stethoscope. So as they are flashing the water through, they are auscultating the chest. But take note, and like I told you, all these are not reliable ways of confirming placement. The placing or flashing with water is even very dangerous, because should it happen that the tube is not within the gastrointestinal tract but rather within the respiratory tract, the water that you have flashed inside, how are you going to bring it back? So please, the best way to do this is to test or use imaging, that is if it is available. But if it is not available, use that of the litmus paper. But do not resort to the flashing with water, placing the end of the tube in a bowl of water, and then other crude ways. Okay. Then you observe the aspirate for color, volume, and the presence of blood. Yes, it's possible the patient may be bleeding, and like I told you, determining the residual volume, that is the volume of food still within the stomach after the previous feeding, is very important before commencement of NG tube feeding. Then we have to check the temperature of the food that we are coming to give. We can do this using a lotion thermometer. After all, the food that we are going to give the patient is going to be in a liquid form. But this is also not readily available. It's usually not there. So the best other way that we can determine this is to drop a little of the feeding at the back of our palm. We use the back of the palm because that has a skin texture similar to that of our mucous membrane. Under no circumstance should you use the palm, because the palm is very rough, hardened, with fewer nerve endings. So the food may be at a higher temperature that you will not know because you have used your palm. So what the palm can resist will not be compared to that of the mucous membrane. So it is always advisable to drop a little of the food that you are coming to feed at the back of your palm to determine the temperature of the food before commencement of feeding. Then, after having done this, the next thing we have to do is to flush the tube with about 10 to 15 ml of water just before we introduce the food. The reasons for doing this is it helps to clear the food, the tube. Because of the aspiration we did, it helps to clear the tube for the feeding to go. The second reason why we would be doing this is to assess whether the patient would be able to tolerate the feeding. it is possible for you to do your residual volume assessment and it is okay. But when you commence the feeding procedure, the patient becomes distressful. So flushing with about 10 to 15 ml of plain water before commencing the feeding helps you to also assess whether the patient would be able to tolerate the feeding without distress. Then, with this, I would like to explain that there are actually two ways by which we can give NG tube feeding. So do not be surprised when you move from one hospital to the other and you see that the ways by which they are giving the food appears to be different. We have two main ones. We can do, even let me say there are three, but the third one is not common within our setting. So I will focus basically on the two. We have gravitational feeding, where the food is suspended from a height and allowed to flow into the patient under gravity. Then we have the push, or what is always known as bolus feeding. I will explain. With the bolus feeding, the food is drawn into a syringe and then pushed through the tube to go into the patient's stomach. That is the bolus feeding. And in Upper East here, I must say that is the commonest that you will be coming across. However, it comes with its own disadvantages because under normal, when we are eating, the food flows to the body through gravity and that of peristalsis. But in the case of the bolus feeding, you would see that the pressure you are using to push the food is going to force the food to flow under a higher pressure into the patient's stomach. So because of that, there's always a risk of the patient experiencing abdominal cramps because of the air and possibly the pressure with which the food was introduced. So that is a main disadvantage with that of the push or the bolus method of feeding. But the gravitational method is the ideal. However, in most deprived hospitals, they do not have the resources to do that. They lack the materials to do that because you need a feeding bag, you need a funnel, you need other things which are not usually there. So because of that, people mostly resort to the use of the bolus push or the bolus or the push method. But where the facilities and resources are available, it is recommended that we resort to the use of the gravitational feeding rather than that of the bolus. Then to do the feeding, be it gravitational or that of the bolus, we give the feed at the required amount ordered. So how do we determine that this is the required amount? Before we commence feeding, that is why we send a measuring jar or a measuring glass. We measure the volume of food that we are going to give, because this patient or these patients mostly are not conscious of their immediate environment to tell us whether they are satisfied or not. So it's important for us to measure the food. Then where you are using the bolus feeding or even the gravitational feeding, we do not want air to rush through the tube and the patient's tummy will become filled with air when we are thinking that the patient is satisfied. So because of that, mostly the tube is clamped. There's that pin we use to open and close the opening of the NG tube. We call that one the spigot. The spigot is always closed. So if you are giving the bolus feeding, before you fix in the food, when you open the spigot, you kink the tube. That is to say, you hold the tube and squeeze it so that air from the atmosphere will not rush through inside. So you pink or you kink the tube, then fix the nozzle of the syringe, then you now push through. When it is about finishing, you kink again and remove and withdraw the food with the syringe. Fix the syringe, release the kinking and push the food through. But in the case of the gravitational feeding, you hang the food from a height. So first you clamp or you kink the tube, open the spigot, connect the feeding bag to that of the opening of the NG tube. Then you release the clamp for the food to flow. Just before the food finishes, you clamp again. All these measures are to prevent air from rushing into the patient's tummy. Then after the feeding process, you flush the tube with about 10 to 15 ml of water. This is very, very important, which at times most nurses tend to ignore. But I will advise that in the course of your practice, always keep this in mind. You know, the food that we are given, some of it will solidify over time. So if we fail to flush the tube after feeding, there is the likelihood that the food particles will clog to the surface of the tube, ending up blocking the tube. So do not be surprised, just some few minutes, few hours ago, you gave a patient, let's say, milk feeding. You gave the patient milk, and then some hours to come, you go to feed, and that tube is not patent any longer, because possibly we have taken and then that calcification and then blockade of the tube. So it's always advisable that we flush with about 10 to 15 ml of water after feeding the patient. So the pinch release, this is what I was referring to. Even though mostly our patients are not conscious after feeding, it's still very important that we congratulate them for the cooperation they have given us. You congratulate or you thank the relatives that are by you too. Then you document the type of food you have given. So patient was given milkshake, patient was fed with light soup, patient was fed with diluted porridge. Then as well, the amount that the patient was able to take. So let's say patient was served with 30 ml of light soup, but patient could tolerate 15 ml. Patient was 30 ml of porridge was served, but patient tolerated 10 ml. Okay. Then you write in the notes the nurse's notes as well as the fluid intake and output chart. This is all as far as NG tube feeding is concerned. Please ask your questions on the platform for clarification. Don't mind the gastrostomy feeding you are seeing. This is not for ours. This is not within our scope. This is mostly for the diploma students. So thank you very much for your cooperation. I'll be uploading the next video or the